Hello, everyone, and welcome to this symposium series, COVID-19 Pediatric Perspective. It is a privilege for me to chair this symposium. Now, this is a joint symposium organized by the British Paediatric Surveillance Unit and the Public Health England. Our aim really is to consider the impact of COVID-19 in children and pediatric services. As you know, this pandemic has had several impacts on different groups of people. Today, we will explore the impact on children. As a delegate, we would invite you to use the Q&A chat box if you need to ask questions to the presenters. The speakers already know that they have 12 minutes to speak, and they will have 3 minutes at the end of their talk to answer the questions that we'll put to them. Please do not use the anonymous and try to use your name. We would like you to tweet about this event using the hashtag COVIDCYP. It's also important that you understand that this event is being recorded so that you can have access at the end of the event. We also publish an email for you to receive a certificate at the end of this meeting today. So this is day one of the meeting. And without wasting much time, I am now going to hand over to Professor Mary Ramsay, who is the head of immunization at Public Health England. She's also been leading the COVID immunization program for the UK. She will do the introductory talk about today's event. Thank you, Professor Ramsay.
Thank you. And I'm not going to talk for very long, but I just wanted to thank you for inviting me, and it's a privilege to be. I understand there are about 1,000 people listening. At Public Health England, we've been working jointly with the Royal College of Paediatrics and Child Health for many years and helped to establish the British Paediatric Surveillance Unit, which has been really very essential in monitoring serious issues in children for many, many years. And we've used it extensively in vaccine preventable diseases. So it's great for me as head of immunisation in Public Health England to have access to that. And the access to that infrastructure allowed the UK to be at the forefront of investigating COVID and its impact on children very early on. And so we've had some great collaborations and some great projects that you're going to hear about later on. Clearly in immunisation, a lot of my focus over my many years here has been on children. But obviously for COVID, the focus has quite rightly been on the other end of the age spectrum, where the bulk of the morbidity and mortality we've seen in almost every country has been on the elderly and the frail, and with really very strong gradients of risk of death and serious complications with age, going much less in younger people, even in those who have risk factors for respiratory disease. But obviously we mustn't forget children, and there are sort of three main reasons why we don't forget children. One is that obviously COVID itself can have impact on children, and you'll be hearing about some of that today. A small number of children who may get very severe complications from COVID itself. The described syndrome of PIMS-TS, which has also been identified and become an important issue, even though it is relatively rare compared to the other complications of that we see in adults. And then, of course, long COVID. But perhaps the bigger problem, and the problems that we're going to be addressing for maybe longer in the future, once we get COVID controlled in adults at least, are some of those indirect effects that the epidemic has had on the paediatric population, both in terms of their general health status and access to healthcare. For example, we've already seen a decline in routine vaccine coverage in our childhood population because of the infrastructure breakdown that happened around the time of the pandemic emerging. And that means we have a population of susceptible children, perhaps susceptible to some of those diseases that we hadn't seen for quite a long time, like measles and those other things. So that's one thing we're going to have to think about for the future, those indirect health effects. plus obviously the larger effects that may have come from the whole lockdown, the school closures, and any impact that's had on childhood development, childhood education, mental health, and economic opportunities that generation may have. So obviously paediatricians are very important in terms of advocating for not forgetting children as part of this pandemic. The third issue I just wanted to touch on, obviously as a person who works in immunisation, is the role of children in transmission. And clearly once we start to vaccinate the bulk of our adult population, the next question that's going to come very soon, and we're already hearing it a lot in the UK, is whether or not we should be vaccinating children. And probably the main reason for doing that will not be to protect the children themselves, but in order to protect the rest of the population by reducing transmission. So that's a difficult question that paediatricians will have to help address. We do it for other vaccination programs, but there's generally a much clearer risk benefit for the individual than we may have at this point, given that very few of the vaccines have been studied extensively in children, although obviously those trials are ongoing. So I think this is an interesting problem for paediatricians to address, and hopefully today you'll get some feel for the sorts of projects that are being done in the UK, and maybe how we can take forward work to looking at the impact of this pandemic on the childhood population as they become our future adults. So that's all I was going to say. So thank you very much, Okike, for inviting me today.
Thank you, Professor Ramsay, for this overview. Just to remind us that we will not be talking about vaccines today. If you want to hear about vaccines, it will be in the next series on Thursday. But today's event will really take you through a journey of past, present, and future of what pandemic is in the context of children. And it is my pleasure to introduce the first speaker, Professor Marian Knight, who is a professor of maternal and child population health at the National Perinatology and Epidemiology Unit in Oxford. And she will be talking about COVID in pregnancy. And please sit back and enjoy her talk. Professor Knight.
Thank you very much. And it's a pleasure to be here. So the majority of what I will talk about today is data from a study using the UK obstetric surveillance system, which is the younger sister of BPSU, established in all obstetric units in the UK since 2005. So we cover all hospitals which have a consultant obstetric unit, and therefore effectively covers the whole birth population of the UK for women who've got severe complications. We've undertaken similarly rapid responsive studies with other emerging infections, notably influenza H1N1 and the Zika virus. And this study was actually established as a pandemic portfolio study 9 years ago. So unlike many studies with COVID-19, which had to be set up very rapidly, we've actually had a study hibernated and waiting to go since 2012, when funding was awarded by the NIHR for a study in that at that point in preparation for another pandemic of flu. But as you can see for this, in February 2020, we were asked to rapidly modify it for SARS-CoV-2. And it was activated on the 18th of March, and then we started collecting data on the 22nd of March. So because it was there and ready, we were able to start data collection very rapidly. And it's one of 4 of a sort of national suite of UK studies of COVID-19 in pregnancy and early life. I will talk a little bit about the confidential inquiry into maternal death surveillance data, but mostly about the effects in pregnant women from the UCOS study. And I will leave the paediatric side of it, the neonatal side of it, to Chris, who's talking after me. So one of the reasons for having a study set up and ready to go in pregnancy is what you can see here. So this increase, this bump here, which is in deaths due to medical and mental health complications, is due to the H1N1 pandemic. So we know that respiratory viruses can have particularly severe impacts in pregnancy, but obviously knowing nothing as we did about COVID-19, it's unclear as to whether COVID-19 was also similar. And just to point out that all of the results that I'm going to talk through here today are from a paper that was published first stage at the end of last month. So over the last year, between the 1st of March 2020 and the end of February 2021, there's been about 7,000 women admitted to hospital with a positive test for SARS-CoV-2 who were pregnant at the time. That's around 1 woman for every 100 giving birth. And you can see very clearly the first wave here, the second wave with the impact of the initial lockdown. The women admitted are not all symptomatic. When we initially, as you would be aware, only symptomatic women were screened on admission to hospital. But since the beginning of June, every woman admitted to hospital to give birth, as well as for any other reason while pregnant, has been screened for SARS-CoV-2. And the paler bars here represent women who are asymptomatic and the dark bars women who are symptomatic. And overall, around 48% of women who are admitted to hospital with SARS-CoV-2 in pregnancy are symptomatic. The women are more likely to be admitted if they are older, more likely to be admitted in pregnancy if they're overweight or obese, and substantially more likely to be admitted if they're from Asian or Black ethnic minority groups. And I've just put these icons here to remind me that it's also if women are hypertensive or diabetic. So very much similar, the same risk factors that you see in the general population. What is different about pregnant women is when we think about the gestation, the stage of pregnancy at which they're admitted. And the majority of women are admitted in the 3rd trimester of pregnancy. If we're talking about women with asymptomatic COVID-19, the majority of those women are coming in to give birth. Their median gestation at admission is 39 weeks. For women who are symptomatic, their median gestation at admission is 35 weeks, and more than 3/4 are in the 3rd trimester of pregnancy. So the 3rd trimester of pregnancy is the particularly significant time. In terms of their outcomes, and I've limited this to pregnant women with symptoms, around 1 in 10 women receive critical care. Around 1/4 have evidence of pneumonia on imaging, and around 1 in 5 require some form of respiratory support. But very few women die, so less than 1% of women die, so around 1 in every 200 women who are admitted to hospital with symptomatic COVID-19. I am always asked whether pregnancy per se is a risk itself. It's difficult to be absolutely certain because of very different thresholds for admission in pregnancy compared with outside of pregnancy. But when we look at UK data, there isn't an obvious increased risk, although I will caveat that with in relation to the more recent Kent variant. And that's what I'm showing on this slide. So on the left, we're just comparing outcomes, respiratory characteristics and outcomes amongst women who were admitted during the most of last year up to November, compared with December to February, when the new variant was more predominant. And you can see that women who were admitted during the time that the new variant became predominant were more likely to be symptomatic, more likely to require critical care, and more likely to need other forms of respiratory support. So I do think that there is a differential impact of that new variant. What I can't tell you is whether that is because women are not being treated as well as if they're non-pregnant, because we do know that receipt of evidence-based interventions such as steroids for maternal indication is very low in pregnancy, and there's clear evidence of women not receiving the care they should simply because they're pregnant. And when we look at the women who die, we can see that overall there's much lower evidence that women are being treated in an evidence way, so clear inequity. But I think you're all here to find out about children and infants, and so these are the data for babies. So overall, looking at symptomatic women, 21% of those women gave birth preterm, and that compares with 10% of asymptomatic women. 18% of symptomatic women admitted during the period March to November gave birth preterm, and I've limited that so that you can see that includes one third of women who are admitted to hospital with infection who go home while still pregnant. So you can see that that does bring down the preterm birth rate very slightly. And overall, looking at these cohort, the figures are very similar. For neonatal unit admissions in around 20%. You can see from these data there appear to be very small numbers of babies who have a positive test for SARS-CoV-2, but I'm going to leave Chris to talk in a bit more detail about those data. So just to summarise, fewer than half of pregnant women admitted to hospital with SARS-CoV-2 infection have symptoms. Of those with symptoms, 10% need critical care, less than 1% die. More than 90% of women admitted to intensive care who are pregnant or postpartum will survive. Use of evidence-based COVID treatments is low. 1 in 5 women admitted with symptoms have a baby born prematurely, and Mary talked a little bit about indirect impacts, and this for me is one of a particularly significant impact because we know the lifelong consequences of being born preterm. And I do think that we need to be aware of the new variants, and I do think there's a differential effect of the B.1.1.7 variant. Many people have contributed to these studies, so thank you very much to all, and thank you to the funders.
Thank you very much, Professor Knight, for taking us through the journey of COVID in pregnancy. Can I just ask you what you think the role of COVID is in preterm deliveries in this period, maybe comparing pre and post during the pandemic and before the pandemic? So
I don't have data on preterm births, and I think it's very dependent on whether you're looking at national data or whether you're looking at centre-based data, because I think we have to be careful when we're looking at centre-based data. There isn't, I think, clear evidence of substantial impact on preterm birth beyond the cohort of women who are infected. And I think it is important to point out that when we're looking at the women who give birth preterm, the majority of those preterm births are actually iatrogenic. So those are births for either mainly maternal reasons, but for maternal or fetal reasons. And there doesn't look to be an increase in spontaneous preterm births amongst women with COVID-19. So from that point of view, we wouldn't suspect substantial increases at a national level.
Okay, just one more question along those lines. I know preterm and low birth weight. There is a question here asking about any data about low birth weight in line with COVID-19 and pregnancy.
So on the basis of the data for this cohort, so that's around 7,000 women now, we don't have any evidence of an increase in babies that are small for gestational age. So that's relatively reassuring.
Perfect. Brilliant. Thank you so much. I think we can save the rest of the minutes left, and Professor Knight will be joining us in the Q&A session at the end as well. So please keep sending your questions through the Q&A chat box, and I will try my best to put all the questions through. And if I don't put it through during the talk, you will have your questions answered at the end. It is now my pleasure to invite the second speaker, Dr. Christopher Gale, who is a reader in Imperial College London, and also an honorary neonatologist at Chelsea and Westminster Hospital, also in London. And he will be talking about COVID and the newborn.
I hope you can all hear me. It's also a very great pleasure to be here. Thank you very much for inviting me, and it's also a great pleasure to follow on from Marian with this talk, which really touches very much on, I guess, some of the issues that Marian's raised. Okay, so I'm over the next 12 or so minutes, I'm going to be talking about how COVID-2 infection impacts on the newborn baby, defined roughly as the first 28 days, the neonatal period. And I think it's worth starting by asking why this group might be different and why we need to consider neonates as a separate population from children and from adults, following on from some of Mary's comments at the beginning. And at the very outset of this pandemic, we recognise that neonates can be affected in different ways. Firstly, there is the indirect impact of maternal SARS-CoV-2 infection that Marian's outlined really very nicely, and I'll touch on that just very briefly in the next slide. There is also the question of vertically transmitted infection, which was a great concern at the beginning of the pandemic. I don't think that has been fully resolved yet, but this transplacental transmission, I think, is an area to consider. And then finally, postnatally acquired infection, both in the immediate early neonatal period following birth to a mother with SARS-CoV-2 infection, and then later in the community. And in terms of why neonates might be different, we, I think, recognise that the immune response of the neonatal immune system is often different to that seen in children and adults. And underpinning all this is a concern that there may be a different impact on neonates from that. And finally, I think we have questions which to this day remain unanswered, but hopefully we will be able to shed light on going forward about the long-term impact of what certainly appears to be in adults and some children to be quite a neurotropic virus. And I think there is considerable uncertainty as to whether infection in the antenatal or early neonatal period may impact on the developing brain. So I'm going to very briefly cover these areas over the next 10 minutes. Firstly, the indirect impact of maternal infection, just to reiterate Marian's data from population level surveillance undertaken through the UK obstetric surveillance system. Just over 20% of symptomatic women with SARS-CoV-2 infection gave birth preterm. This is clearly higher than the background rate we would expect to see in the UK of around 8%. And a similar number of babies were admitted to a neonatal unit, again higher than we might expect in a background population of around 13% in the UK. And there's some data published from lots of other countries as well, a systematic review which included 192 studies, which found this quite consistently. Admission to a neonatal unit was seen in approximately a third in this review of babies born to mothers with SARS-CoV-2 infection. Despite all of these studies reporting this outcome, we actually have relatively limited information about the reasons these babies were admitted to the neonatal unit. Clearly, a lot of it would be related to preterm birth, but we are really missing information as to whether there are higher rates, for example, of neonatal encephalopathy or other concerning conditions. And we have ongoing analysis of data collected through the British Paediatric Surveillance Unit, ongoing surveillance of babies born to mothers with SARS-CoV-2 infection, which we'll be able to show a little bit of this going forward. The second way babies can be affected is through vertically acquired or placental transmission, and concerns were initially raised at the start, certainly in the UK back in March 2020, when we had some reports from China of babies born to mothers with SARS-CoV-2 infection, where umbilical blood sampling found levels of IgM for SARS-CoV-2, which wouldn't be expected to be there following placental transmission of IgG, which obviously does cross the placenta. And so there were some concerns raised at that point. A rigorous definition was then developed by Prakash Shah and colleagues to determine cases of what would be considered definitive vertically transmitted infection. There's certainly been some cases with babies with multiple positive swabs taken from very soon after birth, who then developed symptomatic disease. And also at least one case, quite concerning, of what appears to be confirmed transplacental transmission of a baby with neurological signs and imaging abnormalities who was born preterm, which was published by Vivanti and colleagues. However, despite that, there have been no confirmed cases using the very rigorous definition defined by Prakash Shah and colleagues. And so I think to summarise the current state of evidence, say that transplacental transmission may occur, but certainly appears to be very rare in the context of maternal SARS-CoV-2 infection, certainly with symptomatic impact on the baby. The next way that babies are affected is through postnatally acquired infection. Again, there's been a lot of studies that have looked at this. This is the Living Systematic Review, which is dated by the University of Birmingham, and as you can see, they include 280 studies that have looked at early transmission in particular, so babies born to mothers with SARS-CoV-2 infection, and whether they contracted SARS-CoV-2 infection themselves in the first few days, usually the first 7 days. And within this, they have over 7,000 mothers, nearly 5,500 babies, the majority of whom were tested, but with quite low rates of suspected or confirmed early neonatal transmission. So in this big systematic review, there's about 7%. I think we have to be aware that there appears to be a reasonably high rate of false positives in babies if they're swabbed, certainly in the first few hours after birth. And also that the studies included in that are often not population-based. There's been some further data from the States, which again is quite comparable and paints a very similar picture. Nearly 6,000 completed pregnancies from several areas of the US, and again a low rate of positive tests in babies born to mothers with SARS-CoV-2 infection. So again, just to reiterate some information that Marian has presented, and I'm going to present a little bit more about the UK context in a minute, but early transmission certainly appears to be in the context of maternal SARS-CoV-2 infection. And then babies can also contract it later on in the neonatal period, in those first 28 days. And there's been several large studies. The first one was a multi-centre registry study, which presented data from 82 institutions across Europe. Again, not population-based, but a very rigorous registry study. And within nearly 600 children with SARS-CoV-2 infection, they had 40 neonates. And quite concerningly, they found that 18% of these required what was described as critical care, but with very little further information about how severely unwell these babies were, and including any neonatal admission as a definition of critical care. So a suggestion that maybe neonates, although rarely affected, may be more seriously affected, but difficult to tease out from this registry study. And then subsequent data published from the UK from the ASARIC 4C study, which is collecting information on all inpatients with SARS-CoV-2 infection from the beginning of the pandemic, looked at children across all hospitals in England, Wales and Scotland over a nearly 6-month period at the beginning of the pandemic. And they identified 53 neonates amongst over 650 children. And again, identified that a high proportion of these, nearly a third, received what was described as critical care, but again, including neonatal care. This was a very rigorous population-based study, but again, as Mary recognised at the beginning of this set of talks today, the focus has, for very sensible and largely useful reasons, been focused on ascertainment both in adults and in children rather than focusing on neonates. So on the back of this, and we were undertaking surveillance through the British Paediatric Surveillance Unit here in the UK, which was a prospective population-based active surveillance study using the long-established Paediatric Surveillance Unit process. We were looking at babies that had any diagnosis of neonatal SARS-CoV-2 infection in the first 28 days and were in hospital, and also babies admitted following maternal SARS-CoV-2 infection, admitted to a neonatal unit to look for those indirect impacts on babies. The baby itself was negative for SARS-CoV-2 infection. We wanted to get as close to population-based coverage as we could, so we linked very robustly to national testing data undertaken by Public Health England and other devolved public health testing authorities, as well as paediatric intensive care network data, UK obstetric surveillance, which Marian's described beautifully, and we verified deaths with Embrace UK, the perinatal mortality surveillance system. We looked at data for the first analysis from the first 2 months, where the first peak was occurring in the UK, and over that period, when we would expect approximately 120,000 babies or so to be born, we identified just 66 babies with SARS-CoV-2 infection in the first 28 days. And from the UCOS data, we know that there are at least 300 mothers with confirmed maternal SARS-CoV-2 infection who delivered over that same period. And because we feel this is as close to population level data as we can get, we identified incidence rates. And we can show that the incidence was very low, less than 6 per 10,000 live births. And we also looked at severe disease, which was rather loosely defined as that requiring respiratory support, and found that this also low at 2.4 per 10,000 births. The median age at diagnosis was not in the first 7 days, suggesting these weren't all babies catching it following birth to a mother with SARS-CoV-2. It was actually at about 10 days, 2/3 of these babies diagnosed outside of the first week. Because we had population level incidence, we could look at the incidence rates amongst different populations and found that even in the period, the rate amongst Asian and Black ethnic groups was 4 times higher than what we saw in the white population. And also that the incidence in the late preterm group in particular was also 4 to 5 times higher than what we saw in the term group. We wanted to understand in more detail transmission, and of those 66 babies, we identified 17 that were born to mothers with confirmed infection. And because we were linking with UCOS data, we were very happy that we had good alignment of maternal SARS-CoV-2 infection. 14 of these had confirmed infection in the first 7 days, and certainly over the first 6 months or so, there were lots of questions about what the optimum management was of mother and baby, and whether mother and baby should be separated if mother was known to have SARS-CoV-2 infection. And so we broke these data down, looking at that in a bit more detail, and we found that half of these babies with confirmed infection were actually separated immediately from the mother, 3 to the neonatal unit and 3 to other areas, and despite that still contracted SARS-CoV-2 infection. We also quite worryingly found that 8 of the 66 babies had suspected nosocomial infection, and 6 of these were actually preterm babies who contracted it despite being on the neonatal unit for 7 days prior to infection, suggesting that they really did pick it up nosocomially. That said, the clinical presentation for these babies did appear to be a little bit different from what we saw in older children, with gastrointestinal signs and high temperature predominating. And there were a group of babies who had no signs, who were largely tested because of known maternal SARS-CoV-2 infection. The clinical course for these babies was overall very good. There was 1 death in this group, and that was of a condition unrelated to SARS-CoV-2 infection. While approximately 36% of these babies required neonatal or PICU care, the majority of them did very well. And it's very difficult to interpret this because there was a high rate of preterm birth amongst this cohort. So 1/3 of these babies received some kind of respiratory support. And as you can see, 3 were ventilated, 1 of whom was preterm, 10 received non-invasive support, but again, nearly half of those were preterm, and a significant proportion of the babies that required oxygen were also preterm, and may well have required that even had they not had SARS-CoV-2 infection themselves. What we did see is amongst the babies with early infection in the first 7 days, these babies did particularly well, and only 1 of these babies was ventilated, and that was a preterm baby in this group. So overall, in summary, we can say that the indirect impact of maternal SARS-CoV-2 infection is related largely to preterm birth and neonatal unit admission, and we have ongoing work to try and explore that in greater detail to ensure that there are no other conditions which are overly represented in that population. Placental transmission of SARS-CoV-2 infection appears to be rare, and that symptomatic neonatal SARS-CoV-2 infection is also rare, with most babies only very mildly affected and outcomes really very good in this population. This evidence that perinatal transmission following birth to a mother with SARS-CoV-2 infection is also quite rare. We use very strongly to argue for keeping mother and baby together, even in the context of birth to a mother with SARS-CoV-2 infection. And this has been borne out, I think, by some other cohort studies which have been undertaken with very rigorous postnatal testing of babies born to these mothers, one here in the US and another one in Italy, which have both found very low rates of transmission from mother to baby with just some very simple hygiene techniques and in the context of almost universal breastfeeding. And the babies that did contract SARS-CoV-2 infection were either asymptomatic or very mildly symptomatic and were able to remain with the mothers. There clearly are still some questions in relation to neonatal SARS-CoV-2 infection, and I think overall we are exploring some of these at the moment. Firstly is about what the indirect effects are in a little bit more detail, and understanding, as is the case across all of this research around SARS-CoV-2 infection, why there is an apparent excess in Black and Asian ethnicity groups. And particularly important for the neonatal context is, are there any long-term effects of what appears to be a relatively mild disease in most cases in the neonatal period? And we're very fortunate to have funding through Action Medical Research on a study called the Signpost study, which will be undertaking ongoing neurodevelopmental follow-up of babies through both the UCOS surveillance and the neonatal BPSU surveillance with SARS-CoV-2 exposure in early life. Again, I'd like to thank very much all the paediatricians, research nurses, and all the enormous number of people who helped get this study off the ground at the beginning, and of course the NIHR Policy Research Unit Programme.
Thank you, Dr. Gale, for a very brilliant overview of COVID in the neonatal period. It's just important to reiterate the role of the BPSU in organizing this study, and fantastic results here. If I may ask you just one question whilst we're getting ready for the next speaker. There's a question here: why do you think early transmission is low?
Oh, it's a very good question. I don't know. I mean, I think transmission to neonates appears to be low even in the early and in the later context, given the number of the amount of virus that was circulating in the population. So it's difficult to know, and I think there's a lot of ongoing work looking at the immune response and transmission in neonates in relation to the neonatal immune system. So I'm hopeful we will get some other information in the future, but I think it's certainly very reassuring and has enabled us to certainly move forward with a very sensible approach to the care of babies born to mothers with SARS-CoV-2 infection, which I think is really important, because if we remember back to this time last year or even earlier, there was certainly in the initial phases, there was a lot of separation of all babies from mothers who had SARS-CoV-2 infection around the time of birth, which may well be leading to quite detrimental effects in terms of relation to bonding and also to breastfeeding. So I think it's been very useful to have this information to strongly support keeping mums and babies together.
Brilliant, thank you. And finally, do we know anything about congenital defects or impact on developing fetus?
So we haven't looked at congenital defects within the context of the BPSU surveillance program. It's clearly not set up for that. There are other surveillance systems that are looking at that, so I can't really comment on that directly. I think the question of the developing brain is a very important one, and as I said, we're very fortunate to have funding now to be undertaking ongoing neurodevelopmental surveillance of babies that are affected in pregnancy and in the neonatal period. So we should be able to answer that question robustly using this fantastic population level data that we've been able to obtain both through UCOS and the BPSU systems.
Okay, we look forward to hearing about that. There are a few other questions, but we can bring it to the Q&A session at the end. Now, this brings me to the next speaker, Professor Shamez Ladhani, who is a professor of pediatric infectious diseases and vaccinology, and also a consultant for Public Health England. And he has been leading the surveillance in children and will be presenting COVID-19 surveillance in children today. Please pay attention.
Okay, thank you very much. Well, thank you for giving me the opportunity to talk at this meeting. I wanted to start by trying to explain that I have a title that is actually very difficult to talk to in a 2-day seminar on COVID in children. So what I've done is try and focus a little bit on what we understand about SARS-CoV infection and transmission in children using national surveillance data and what we have learned over the past year in terms of the role of children in the pandemic. And just to give you a little bit of context, in England, we have had what we think are 3 waves. In the first wave, you will see the bars in brown and green, which are looking at testing. Pillar 1 is hospital testing, Pillar 2 is community testing. And what you will see is that we had very little testing in the first wave of the pandemic, but we had increasing testing since around week 30, which is around June time, which gives us a better idea of the true infections rate. But if you look at the positivity rate based on the dotted lines, you will see that we had a massive outbreak in the first wave of the pandemic, which wasn't measured by the positivity rates. And what I want to do is focus a little bit on the second wave of the pandemic. And the reason for that is that when the first wave came on the 20th of March, we closed all our schools, and then we went into national lockdown, which resulted in large numbers of cases, large declines in cases from the first pandemic. And in the summer, we had a very good few summer months where we had very little infections in the community or in the hospital. But in September, the schools reopened, and following the reopening of schools, we started seeing increasing numbers of cases. And one of the big problems was trying to understand whether it was the infections in the community that was driving school infections, or whether it was the school that was actually the hub of infection and infections were spreading from schools. These are national surveillance data. You can find them on the gov.uk, and they're updated every week. There are certain components to this that I want to discuss before I explain to you. First is, these are all the positive SARS-CoV swab testing in the country for England. So they require somebody to go to a testing center and get tested, and therefore the vast majority of them are either symptomatic with COVID, or they have been a contact of a case and want to make sure they don't have COVID. What it doesn't take into account is asymptomatic infections, which is what we see in the with the ONS infection survey, for example. But even though this is only symptomatic testing, the trends that you see over time should still be applicable, and that should not change, because the proportion that get tested should remain consistent throughout. And what I wanted to start off with is that our school started on the 31st of August, and I wanted to make the point with the first circle that cases in children, which are the red lines, started going up before the schools opened. And if you look very carefully, what you see is that it is closely reflected in the increase in cases in the adults. The solid blue line is 18 to 29-year-olds who are the main drivers of infection, and the dotted blue lines are all adults aged 18 to 64. And their cases started going up before the children's cases went up. What I wanted to show you is that the cases in adults continued to go up very rapidly and then plateaued from October to November. And that allowed a lot of transmission in the community, and children's cases continued to increase during that period of time. From the 2nd of November, we went into national lockdown, and what you see over here is that cases in adults started going down very quickly, and then the children's rates fell after that. Even though schools remained open during that time, the cases reflected more closely the adult cases rather than what's happening in schools. And then there is a final component that I'll talk to you more about, where you will see the dark red line actually shooting up very quickly in line with the adult cases. And this was because of the emergence of the B117 variant, which was affecting all age groups, including children who were going to school. And you can see these trends in all different parts of the country. You can take the regions and look at them separately. And you see the same trends again, adult cases shooting up and then childhood cases going up. When adult cases go down, childhood cases go down as well. And those were consistent throughout the different regions where there were sufficient cases. And what we have shown from all the way back in June is, even during a period of low community infection rates, the rate of infection in children correlates very strongly with community infection rates in the adults. The gray line is a secondary school, the orange line is the primary school, and the blue line is the preschool cohort. And what you see on the x-axis is, as the weekly community infection rates go up in adults in the different regions in England, the incidence in children also goes up, even when there is low community transmission. And you can take a very high community transmission and the correlation gets stronger for all age groups. So when you have a community with a lot of infection, you will see an increase in the different age groups, and they will be affected differently by age. So you'll get many more cases in secondary school compared to primary schools and preschools. Again, these are symptomatic testing, but they do show that there is a very strong correlation with what happens in the community. The next bit I wanted to make you aware was that we had the B117 variant that appeared at the end of November, which led to another national lockdown in December, January and February in England. And again, what you will see is that as soon as adult cases started going down, the children's cases also started going down. And importantly, I wanted to make this point, which is not well reported, is that adults continue to remain in lockdown, but children went back to school for 3 weeks in March. And as a consequence of that increase, what you see is a small increase in childhood cases. But this represents 9 million children going to school in England, and we had a small increase in cases without any effect in the adult age groups that was measurable. You can see that a little bit better in the same graph in that little bit. You can see the increase happens in primary schools and secondary schools, but not so much in the college groups who did not return to university, or in the preschool cohorts where they continue to remain open throughout the lockdown. With this increase in childhood in children going back to school, these are hospitalizations in children, and I wanted to provide the data in the context of adults and older adults, and the lines at the bottom, which are essentially the 0 to 4-year-olds and 5 to 14-year-olds, you can barely see because the hospitalization rate was extremely low during that period until April, and the ICU admission rates also remained very low, even when schools were open for 3 weeks, with 9 million children attending the school at that time. What was very interesting is that the PHE in England monitors outbreaks in educational settings, and during September to December, where we had the full reopening of schools, we had almost equal number of primary and secondary school outbreaks, but there are 5 times as many secondary schools as primary schools, which means that there were 5 times as many outbreaks in secondary schools as there were in primary schools during that period. But the reopening in March was very, very different, and that was partly because we started providing twice weekly testing for all secondary school students and all staff in schools during this period. So they get tested twice weekly at home, and they're meant to isolate if they're positive. The other thing that changed is secondary school students were asked to wear face masks in the classroom, which was different to the first part where they were only asked to wear a mask when they're in corridors. So either of those 2 effects could be responsible for the fewer outbreaks in secondary schools. So my second part of my talk that I wanted to quickly bring you up on, which is actually hot off the press data and very, very new, is what happens. We do know that children behave differently to adults. We know children are much more likely to be asymptomatic. But the one message I want to get clear is that children do get infected. And if you do population-based antibody studies, you find a very high rate of seropositivity that is not very different to adults. That tells you that children are as likely to get infected as adults, and they develop antibodies just like adults do, except that they are more likely to develop asymptomatic infections, and that's why you don't pick them up when you do PCR testing. There's a really nice study, and there are several of these. I've referenced this one from the JAMA Network Open, which basically modeled the amount of antibodies that you make after infection in the different age groups. And what you see over here is that not all children are the same. The amount of antibodies that are made actually is highest in the 1 to 10-year-olds, and then it goes down in the 11 to 18-year-olds and further in the young adulthood. So younger children make more antibodies when they're exposed to SARS-CoV than older children. These are complicated graphs, but I just wanted to bring out the messaging again, showing what I showed you before. If you look at the IgG antibody titers in 0 to 25-year-olds, the amount of IgG antibody you make goes down over that age period. And if you look specifically at the receptor binding antibodies as well, the bit that actually is probably protective against infection, that also goes down with age, again telling you that the amount of antibody that you make actually declines with age. So the younger ones make a lot of antibody, but if you look at the information below, the quality of the antibody is very, very different. So the ability of those antibodies to neutralize or to attach to the virus actually is lowest in the younger age groups and increases with age. So younger children make a lot of antibodies, but they are not as good as the older children who make less antibodies, which are more efficient. We have been conducting surveillance in school children since the start of the pandemic. In June, we recruited 192 primary schools across the country and followed up 138 of them. And within that group, we had a subgroup of 49 children with 12,000 students and staff who provided regular blood samples during the school term. And again, with our school surveillance, what you do see is that the antibody positivity rate in staff and students was not different. It means they were very similar, and also they were very similar to the local community infection rates, which means that, again, children do get infected and they do develop antibodies just like adults do. They just are more likely to be asymptomatic or mild and transient. This is primary schools and this is secondary schools. So the importance of this one is when you are looking at any study that are symptom-based or PCR testing-based, they will not accurately reflect what's happening in children because most children will be negative for both. And in our studies, we found that 80% of primary school children who developed antibodies while in school had no symptoms at all, and 70% of secondary schools. That compares to about 20 to 30% of the staff who were asymptomatic. So 80% of staff were actually symptomatic with their illness. We have unpublished data that hopefully will get published soon, but again, showing the same thing is that when you look at primary school students compared to the teachers, they make much higher amount of antibody levels against spike, nucleocapsid, the receptor binding domain, and the N-terminal domain. And these antibodies are retained for more than 6 months after SARS-CoV infection. We also find that these antibodies provide very strong protection against other coronaviruses in children, but not so much in adults. And it is specific to coronaviruses and not to influenza. Same thing again with cellular responses. We found a very high rate of T-cell responses in children directed specifically at the spike protein, and children were able to mount a much stronger cellular response compared to adults. We also identified a differential cytokine response in children where the cytokine profiles of those after 6 months was very different in adults compared to children. And what was interesting is that we saw some evidence that maybe children can retain antibodies better than adults, but this was a very small sample size and we needed more information. And we need bigger sample size to confirm this. So just to conclude my talk, I wanted to send out the message that children do get infected, and it is likely they are as likely to get infected as adults do. But most children develop mild or asymptomatic infections, which may actually make them poor transmitters of the virus to other children and adults. Severe COVID and death is rare, even in children with comorbidities. And there is an association with age, with the youngest having the lowest risk and the oldest children having a higher risk. Cases in children closely reflect community infection rates. So by keeping the infection rates down in the community, we can protect the children and allow them to stay in schools. We also found no evidence that children are driving infections into the household and wider community. That doesn't mean that that doesn't happen. It does happen, and some children will infect household members and other community members, but this is not what is driving the pandemic or the community infection rates. We're able to show a robust immune response to SARS-CoV infection in children, which is targeted specifically at spike protein and lasts for at least 9 months in children. We do need more information about the duration of protection and cellular responses in children compared to adults. Thank you.
Thank you, Professor Ladhani, for taking us through the pediatric surveillance in the UK and really exciting results. I'm afraid I haven't got time for a specific question now, but we'll be delighted to have you at the Q&A session at the end. Every pediatrician, it's always very happy to give a voice to the child. And as part of our symposium, we have a fantastic group of young people who will be talking to us now. So this is a group called RCPCH Us. These are children, young people and family network for the Royal College of Pediatrics and Child Health. They bring together hundreds of volunteers each year to help inform health policy and practice. And members of this group have formed a COVID book club, and they're here to share what they have done over the pandemic period. And we're really very grateful to Emma, Owen, and Phoebe, who are joining us via video to share this wonderful innovation. Thank you.
Whilst reflecting on the COVID-19 book club project, we decided to think about its purpose. Whilst in lockdown, we wanted to make a difference to how children and young people's voices were represented across the health and social care sector. Having discovered a lot of reports on children and young people's experiences during lockdown, we wanted to bring together a lot of voices just into one report. It was clear that the children and young people's voice needed to be amplified across medicine and health services, and by bringing together several reports into some clear, concise priorities, we could share these with the sector and NHS trusts for maximum impact. From the outset, our aim was to support services to know how to better include children and young people's voices in their work, and our research aimed to make it easier for them to do this. We wanted to produce some clear findings which would be more likely to resonate with NHS trusts. This is why our 3 priorities made it easier to share and made our findings more impactful and more likely to be actioned. As a group of young people, we wanted to find a way of including children and young people's voices in the research in a less tokenistic way. Being able to carry out our own research from start to finish meant that we could ensure that the children and young people's voice was projected throughout, and it helped towards our original aim of improving representation of children and young people's voices across the sector. From the start of the project, each member also had their own reasons for wanting to be involved in the research. Personally, being a young person who has a family member who was accessing health services throughout the pandemic made reading the reports a lot more interesting, as the topics resonated with me. Having a group of young people who had a vested interest in the project and the topics we were discussing helped us see it through to completion and made sure that we had high quality findings. When discussing the purpose of the project, we also reflected on the benefits of having a virtual meeting each week. Despite the differences of conducting research whilst working remotely, we found that having an hour-long meeting penciled in every week gave a reassuring sense of structure to our week, and also being tasked with reading reports gave us something new to work on. This was especially important for group members who were shielding. Overall, having a group with a mutual interest in making a difference to the representation of children and young people's views across the health and social care sector meant that we were able to deliver timely, concise and clear objectives which we've successfully shared with NHS trusts.
We appeared to plot out the project without even intending to, which, looking back, really helped to make it a success. We would read and analyse the reports one week, and the next week we would invite an expert along to our meeting and ask their advice, either on the analysis itself or how they would use the information to form more in-depth conclusions. When the doctors and policy experts, who all contributed greatly to our research, assisted us at the time, we would make notes, and some things would make complete sense as to what was happening, and we would see us through a particular moment that we might have been struggling with. However, looking back, some of the notes I certainly made, the advice they gave have actually helped long-term with other opportunities. You can really tell that these people are experts and have seen through projects in the past. They really do base their advice on their experience, so what I would say is keep hold of any advice you receive, because it may not be useful now, but it probably will be at some point. Since the book club itself, our group has chaired roundtable events, led debates, been part of panels, seminars and other online discussions. Our aim was to read as many reports as we could, to get as many young people's voices heard so they could be part of the project and ultimately our results. During the project, in order to find the common themes in the reports, we set ourselves these topic time sessions where we would all go away and each of us focus on a particular issue. Where was the mental health impact in a particular report? Where were the family impacts of lockdown? We would then come back the next week and analyse even further and conclude that specific reports showed that lockdown was having a greater risk on a specific element for young people in a specific area of the UK. Another thing we found worked really well was that we made it work for each individual involved. We all had that one regular slot in lockdown and it gave us some normality. But at the same time, some of us were studying, working, some were even shielding, and the book club still carried on. There was a certain amount that could be done each week, but it became flexible. Anyone could do it, because we all had the end goal of reaching those themes in the analysis. We said that time wasn't on our side at our first meeting last summer, as we didn't know when the lockdown would end, and when the project did start to develop, society was obviously starting to open up again. However, as much as COVID has sadly dominated even the last 6 months since our project paused, it's meant that people still want to hear about what we did, what our priorities were, and how they can use it to their benefit in the future. Time may have been against us at first, but looking back, the project has brought the group back together through the many opportunities that are still happening. So many lessons have been learned as a result of COVID-19, and that is important, but we can also reflect on the fact that because COVID and its impact will be here for a long period of time, so will the impact of a project like this one. So let's continue to build on that.
Hi, my name's Ella, and I'm part of the COVID-19 book club. And I'm going to briefly outline some of the main points that have come out of all the research that we've done as a book club. So that's 6 of us young people, along with a trainee and RCPCH staff, Emma and Suban. So after having reviewed all of the studies and identified key themes in those studies, we now want to make sure that all of the children and young people's wishes that we read about are highlighted and fully understood. So we want to support the NHS to include children and young people's needs in all of their recovery planning and winter planning. What we've done, we've identified 3 main recovery plan priorities, which I'm going to outline now. So the first priority is about pandemic information for children and young people. So under 25s found that accessing information about the pandemic and health services was unclear and confusing, and it was rarely aimed at them, so that it didn't really feel relevant to them. And they also weren't sure if they could get NHS help for non-COVID-19 concerns. So our recovery plan priority here suggests working with local youth groups to create more youth-focused messaging. So this could include things like virtual visits to local schools or groups to explain local guidance and service access information. It's hugely important for the pandemic guidance made for children and young people to be made readily available to them. So that's our first recovery plan ask. Our second one focuses on mental health services supporting children and young people. So those whose mental health has been impacted by the pandemic reported feeling confused about how to get help with mental health, as they don't want to bother anyone during such a time. So our ask here is for recovery and winter plans to provide a space for children and young people to talk about their pandemic experiences and appointments. So whether they're directly or indirectly linked to strictly health-related issues. Other solutions could be providing online training about mental health, using resources such as psychological first aid training or mind-ed resources. Recovery plans could also include online mental health drop-in appointments that are specifically targeted at children and young people. So now moving on to our third and final recovery priority. This one looks at creating the best virtual health service experience. So children and young people have reported feeling overwhelmed by the transition to a virtual experience, some feeling as if no one wants to see them face to face. So it's been difficult for some children and young people to open up online or on the phone, especially from home where families could be listening in. Children and young people have also spoken about connection issues and lack of resources to book online appointments. So our ask as a book club is that recovery plans ensure that children and young people know how to ask for a face-to-face appointment if they do need one. Videos and graphics would be the best way of ensuring this. So these could kind of explain how virtual appointments work and be specifically aimed at younger patients. Patients need to be supported to help them create a safe, confidential and private space to have health appointments virtually. So those are our three main recovery plan asks, briefly outlined. And so about information, mental health and virtual experience. But we do have a lot more information on all the work that we've done, which is on our webpage.
Okay, so I'm just going to speak on behalf of a couple of the other members of the COVID Book Club about people in place. So as you've heard, there was lots of different people that have been involved in the book club. And I think this is one of the key things that the COVID Book Club has reflected on, that actually it really worked well because it was a 360. So we had everybody involved and they all had a role to play. And I think if you're thinking about different children and young people getting involved in your COVID research or other academic research, really think about all the different roles they can play and how actually that can meet their needs and how many different types of people you can get in to help you check and think and review and understand everything that you've done. And as you've heard, everybody had their own personal reason as to why they wanted to be involved, either because they were shielding themselves or they had a personal interest, or actually, they wanted to contribute to the COVID effort when maybe they weren't able to as volunteers or as staff members because of other reasons. So really, it was the people that made this project such a success. And we're really, really thankful that everybody got behind it and got involved. But I guess one of the other bits is about place. It was a completely virtual project, and that was the first time we'd done something like this. So as you've heard from some of the young people, our top tips were about being adaptable to what we did and to really, having some regular meetings, making sure there's a routine, but really thinking about actually, where people are at in their own place and environment, and giving them opportunities to do things that they're able to do in their own time and in their own way. So we made lots of use of different collaborative tools online, and making sure actually that we created a safe virtual space that also followed our own priorities. So we had good information, we had good mental health support, and we also made sure that actually, as a virtual project, it worked well for everyone involved.
So yeah, thank you so much for listening to us from all of the COVID-19 Book Club, and I hope you have a nice day.
Okay, thank you very much. Isn't it wonderful as a pediatrician that we keep giving voices to children? And just as a kind of announcement, if you want to hear more about what our young people are doing, come to the Thursday webinar. I've also spotted some questions asking about vaccines and also other viruses in the pandemic. This is covered in the next symposium happening next Thursday. So join us that day to hear about this. It is now my pleasure to now welcome Dr. Godwin Oligbu, who is a consultant pediatrician and with interest in pediatric infectious diseases. He's also a senior research fellow for Public Health England and St. George's University of London. Godwin will be talking about pediatric multisystem inflammatory syndrome and using, again, another BPSU study to highlight the importance of surveillance during the pandemic.
Thank you, Dr. Okike, for the invitation. And it's my pleasure to speak in this webinar. I'll be talking mainly on PIMS-TS, and most of my discussion is going to dwell mainly on the outcome of our national surveillance here in the UK and Republic of Ireland. And PIMS-TS, the full meaning is Pediatric Inflammatory Multisystem Syndrome, temporarily associated with SARS-CoV-2. US has a different name for it. They call it multisystem inflammatory syndrome in children. But essentially, it both means the same thing. And briefly, I'm going to just introduce this topic. Children currently make up only a small proportion of COVID-19 cases and deaths in this pandemic, and accounts for less than 5% of cases in Europe. And the vast majority of children do not require hospitalization, and only very few of them eventually end up in intensive care. The symptoms and signs of PIMS-TS share similarities with both Kawasaki that we know and toxic shock syndrome. and they are usually characterized by either a single or multi-organ dysfunction. We have also seen less serious presentations, such as abdominal pain, vomiting, and diarrhea in children presenting with PIMS. The first cases were first identified in London in April last year, and soon after that, cases have been reported worldwide. In the US, over 1,600 of cases were reported early this year, and 26 deaths was associated with those number. And majority of them, over 98% of them, were tested to have SARS-CoV-2. But I must say at this junction that for the US study, they included a positive COVID test as a criteria for inclusion in that study. So we know that there appears to be a temporary relationship with COVID-19, with PIMS-TS, but a causal relationship is yet to be established. So here in the UK, Public Health England initiated a rapid surveillance of PIMS-TS. And at the same time, we did surveillance for Kawasaki disease and toxic shock syndrome in UK and Republic of Ireland through BPSU. We've been using British Pediatric Surveillance Unit for over 3 decades now. Pediatricians across the UK and Republic of Ireland were asked to report any case of PIMS-TS monthly. Usually we have over 90% of pediatricians responding to this and submitting their orange card, even if there was no case identified. We included cases diagnosed between the 1st of March and 15th of June. We had a robust case definition, and our inclusion criteria was children less than 16 years old, having fever less than 38 degrees, and CRP over 100 milligrams per liter, and any of one of these organs involved, either a cardiac involvement or a gastrointestinal involvement, either having a respiratory failure needing support, or raised other inflammatory markers of ferritin or the dimers more than twice the level. And all the children that were included must not have any other diagnosis or other pathogen identified except SARS-CoV-2. Here is a summary of the flow chart of cases that was submitted to BPSU. In total, we had 449 cases, but after excluding those that were duplicates, those that did not meet the PIMS criteria, and those that were purely Kawasaki and toxic shock syndrome with no associated PIMS, we had 268 cases that met the criteria and was included in the analysis. And out of the 268 cases, 216 was PIMS only, and 13 cases was PIMS with associated Kawasaki syndrome. We had 28 which had PIMS and some futures associated with toxic shock syndrome, and we had 11 that had PIMS and some futures that had overlapping Kawasaki syndrome and toxic shock syndrome. We tried to estimate the risk of PIMS in England, and we were able to do this by estimating the number of COVID-19 cases in children during that period. And this data was obtained from the study in Cambridge, and they had about 527,000 cases of children that was estimated to have had COVID during the period of this study, out of which 1,306 was below 5 years old, making the incidence to be about 57 in 100,000 of cases of PIMS in that age group. And for over 5 years old, we have 391 cases that had COVID and making the incidence to be about 41 per 100,000 cases. We then compare this incidence with our known incidence for Kawasaki disease. We estimated that incidence of PHE should be about 45 in 100,000 children, which is almost about 10 times the incidence we have for Kawasaki disease, which range usually between 5 to 10 per 100,000 cases. What were the demography of this data we obtained? In England happens to be the majority of cases. Over 90% of PHEs occurred in England, and London had the majority of cases. Only 11 in Wales, 6 in Scotland, and 3 cases in Republic of Ireland, and 2 cases in Northern Ireland. Let me remind you that this is just the first wave of the pandemic, and this does not include all the waves yet, which analysis is ongoing. Interestingly, the median age was above the age of 8 years old for these cases. And if you compare it with Kawasaki, where the median age was less than 5 years old, and the ethnic minority were more in these cases, and even male were overrepresented. About 1/5 had underlying comorbidities, and 13% were overweight, and almost half had the confirmed cases with COVID. And interestingly, 77% had a parent who was a healthcare worker. And looking at the map of the UK, you will see that they had a clustering of cases, but cases spread all over. And we look at the trend of these cases, you will find out that this red line depicts the cases of COVID nationally, and these bars depict cases of PHEs. And you follow that, you find out that it follows a trend. After the peak of COVID cases, we now have the trend in different regions of the UK. And what are the clinical features? The commonest clinical features we have is gastrointestinal involvement, and half of them had cardiac involvement. 87% of them had low albumin, and almost half required PICU admission. Only 15% had PCR positive, and 64% had antibody positive. But remember that this is during the first wave where testing was limited. When we compare the PHEs features, we find that most of the cases that we had, the PIMS with associated toxic shock syndromes were more common in ethnic minority, and they are more likely to have PICU admission, more likely to be ventilated, more likely to require nootrops, and more likely to have long stay in the hospital, and more likely to die from it. We did an interesting thing using a software package to estimate the latent class analysis. And this figure here shows a geographical representation of the different classes that we identified by the latent class analysis, and the probability that the observation we had belongs to each different group. The first group is those that depict the PIMS only. This second group depicts PIMS with associated Kawasaki disease, and this last group is PIMS with associated toxic shock syndrome. And when we compare those 3 classes, we find that class 3, which depicts PIMS with associated toxic shock syndrome, are likely to have cardiac complications or cardiac involvement, are likely to be hypotensive, they are likely to be tachypneic or required respiratory support or be confused. But those in class 2, which is PIMS with Kawasaki disease, are likely to have Kawasaki-like rash, conjunctivitis, or Kawasaki lips. We also know that those in class 3 are likely to have abdominal symptoms such as vomiting, diarrhea, or low abdomen, but we did not find any differences with neurological involvement. When we look at the treatment, virtually all the cases had antibiotics received. Only have received antivirals, and 81% had anticoagulants, including aspirin, and 76% received immunoglobulin, and only 3.7% had monoclonal antibodies. We also did an extensive literature review of these cases, doing a systematic review. And we found that most of these cases are consistent with what we find in the UK. The study by Bille and colleague, using 1,700 children, found that male was predominant, and 71 of them were Black as well. And the severity of these cases was more in 18 to 20 years old compared to less than 5 years old. And gastrointestinal symptoms and rash and conjunctival hyperemia were more common. They also had a lot of cardiac dysfunction of about one third of them. And nationally, it follows the COVID peak cases, their PIMS tiers as well. And death in those cases was rare. The other one we reviewed was a paper from Godwin Oligbu, which has 85 cases in their review. And the majority of them tested positive for SARS-CoV-2. Rash, diarrhea, and vomiting was the majority of symptoms that was presented. And they had a lot of cardiac artery dilatation and aneurysm, and only one infant died. But in conclusion, they felt that infants felt to have milder cause of PIMS or MIS-C, as they call it in US, than older children, and most of their symptoms tend to resolve. In summary, we observed there was a temporal and geographical association between PIMS tiers and COVID-19 cases. And this usually lagged about 16 days from the peak of COVID-19. And these cases differ in age, ethnicity, clinical presentation, and cardiovascular involvement and severity. And the latent class analysis we did identified 3 different classes with some specific characteristics. Interestingly, 77% of these children had a parent working in healthcare setting during this first wave, and 56 cases of these PIMS tiers did not meet the criteria because CRP was less than 100, and this is most likely going to be a milder form of the spectrum. In conclusion, there is a strong association between SARS-CoV-2 infection and PIMS tiers. This emphasizes the importance of maintaining a low community infection rate to reduce the risk of PIMS tiers, and understanding this relationship between SARS-CoV-2 infection and PHE could provide useful insight into the pathology of Kawasaki disease and toxic shock syndrome. We continue to follow these cases up and monitor them for complications long term. Thank you. I want to acknowledge those that helped us during this study. Thank you. Any question?
Thank you, Godwin. I haven't got any time for a specific question. However, we would love to have you at the Q&A session. Please keep sending your questions through the live Q&A chat box. Now, again, this is a typical example of how the BPSU have led the response to this pandemic in the UK. I did say at the beginning that it is a pleasure to be chairing this important meeting. I've never introduced a sir before in my life, so it is my pleasure to introduce Professor Sir Terence Stephenson, who is a Nuffield Professor of Child Health at the Institute of Child Health and University of College London. He was also the past president of the Royal College of Paediatrics and Child Health. Like I said earlier, we are looking at the past and the present, but we're also thinking about the future. And Professor Terence will bring us up to date with the thinking and the planning for long COVID in children by presenting his study, the clock study. Professor Terence.
But thank you for inviting me. When I was vice president of the college, I was responsible for the. It's wonderful to see its huge contribution presented today to the ongoing work on COVID. I think I'm going to be the only one who's going to show you any data, because Okike says this is about what we're going to do, not what we have done. But I nevertheless hope you'll be interested in this national study of long COVID. So Jacob, if I could have the next slide, please. Okay, this is what I'm in the next 10 minutes. Why we're doing this study, what we're going to talk a bit about involvement, including young people, and what we hope the study will reveal, and some strengths and weaknesses, and then we'll have the general panel Q&A session. So, Jacob, the next slide simply shows that this is a national study with collaborators from all across the UK, which is important. I think we've got national coverage. And the next slide, please. And the next, please. So why are we doing this clock study funded by the NIHR and UKRI to the tune of 1.36 million? That's because there's been lots of anecdotal and case reports and small surveys of long COVID in young people, but no systematic geographical cohort study worldwide. And researchers, we all think this is a maxim I think we would all adhere to. We need to believe what we see, not see what we believe. Be really careful at the minute. A lot of stuff entering the media about what long COVID is, and the only way to find out what long COVID is in children and young people is actually to research it. There's a number of possibilities, but what makes our study different is that we're going to actually ask young people. You couldn't have a more public involvement study than instead of pediatricians telling young people what long COVID is, we're actually going to ask them about their symptoms, as you will see. And if I go to the next slide, please, it may well be that long COVID is not a single condition. So this is just speculation on my part, but there could be more than this. You could have persistence of the virus in the body. So far, little evidence of that. You could have an autoimmune disease where antibodies generated against the SARS-CoV-2 virus actually cross-react against the child's tissues. You could have persisting organ damage, so no longer the virus in the body, but damage to the lungs or the CNS or the liver. You could have some kind of post-traumatic stress disorder for children who, say, had experienced PIMS or been on ICU, or perhaps had a parent who'd been severely ill. They're all possibilities, and at this stage, I don't think we can say long COVID is any one of these things. And the next slide, please. So this is the crux of the study. It's called a matched cohort design, where Public Health England, and one of my collaborators on this called Shamez Ladhani, is both at St George's and Public Health England. Public Health England have a record of everybody in England who's had a COVID test, positive or negative. And the information we have is a name and postal address. So we contact young people by writing to them and inviting them to take part in our study. And if they agree, they go online and complete an online consent form and then fill in a questionnaire about their physical and mental health. And we aim to initially about 15,000 COVID positive young people and 15,000 with a negative COVID test on the basis of the SCID study with about a 20% participation rate. So we're hoping to have 3,000 young people aged 11 to 17 who tested positive, and a comparator group of 3,000 young people who tested negative. We've already got over 2,000 consented at the first 9 days, so it's going very well. Those young people will be contacted actually 3, 6, 12 and 24 months after the COVID test, and we'll be inviting them to tell us what symptoms they have, both physical and mental. Next slide, please. So this is our hypothesis. We think that obviously the young people who tested COVID negative will still have lived through a pandemic. They will still have faced disruption of their friendship groups, social isolation, school closure, interference with exams and applying for university. So we imagine that all young people will have been affected by the pandemic. but are the type of symptoms, physical and mental, how often they occur, and how long they will be different in the COVID positive children from the comparator group. And we will use that data to arrive at an evidence-based definition of what long COVID is in children and young people. So rather than starting with pediatricians telling young people what it is, we'll use the data we generate to arrive at a definition. And if I go to the next slide, please. So I mentioned we've already got 2,000 participants. This is the biggest survey I know of worldwide. To date, the biggest survey I've seen published was a self-selected group of just over 500 from mixed review. I think UK, Italy involved, people recruited through, I think, social media. So we're hoping that our study will be more nationally represented and span the whole of England. And the next slide, please. So this is what the study should reveal. We will have, as I said, an evidence-based what long COVID is in 11 to 17-year-olds from the. We can use a technique called latent class analysis to find out where there are symptom clusters, which may or may not correlate with those 4 types of long COVID I spent on initially, or may indeed show completely new groups. In adult long COVID, it's looking like there's a sort of respiratory cluster with cough and ongoing shortness of breath, and a more neurological cluster with brain fogging and cognitive problems. So we'll need to look and see whether we see that in young people. And we'll be able to define the prevalence at 3 months, at 6 months, at 12 months, and at 24 months post-infection. So next slide, please. We've already got 2 study extensions. The funders asked us to use a Delphi consensus test that I don't have time to go into, but to advise not just to use raw data, but to have a group of experts. What I will say about it is we were keen to include 2 groups in that. One is it won't be the research collaborators who are doing this. It will be frontline clinicians, doctors, nurses, GPs, pediatricians, A&E specialists. And it will involve carers and young people, which I think may be the first time ever that carers and young people have been involved in a Delphi consensus technique. And secondly, we identified that the NIHR funded several studies, but there was a gap of the 18 to 20-year-olds, because our study as pediatricians obviously went up to the age of their 18th birthday. And the other big adult study, which recruited from the Millennium Cohort study, young people born in 2000, obviously didn't have anyone in it under the age of 21. An extension, although we're pediatricians, with our adult colleagues to also study 18 to 20-year-olds, because we think that's a very important group of young people who the pandemic will certainly have affected, and we've applied for Research Ethics Committee for permission for that. And then I've got 3 slides to go, Okike, if you can just bear with me because there's a delay between each one. Can I have the next slide, please? The involvement of young people has been critical to us as child health professionals in this, putting this together. So we involved young people and their carers before we submitted the application for funding. We involved them post application, having got the funding, in preparing our submission to the ethics committee and in deciding how we would recruit young people, approaching them with a postal invitation initially, and then online. One of the very interesting things from the 2,000 we've already recruited is about 3/4 of young people use a mobile phone to complete this questionnaire. So having a technology platform that allowed that and a QR reader that allowed them to go straight to the website has been critical. And I've mentioned that the Delphi panels will also involve young people and carers, which I think is a huge step forward. And then the next slide just highlights the strengths of this study methodology. So the strengths are, as I've said, we do not start with an arbitrary definition of what I think as a consultant pediatrician what long COVID is. Rather, we ask 6,000 young people what symptoms they're still experiencing at 3, 6, 12 and 24 months. And we use that to come up with the definition of long COVID. And absolutely critically, a major strength of the study is we have a comparator matched cohort of children and young people who've lived through the lockdown, who've had school closure, who've had social isolation, but who have never had a negative or never had a positive test, only ever had a negative COVID test. So they are our control group. And that final slide, to show humility, shows that there are some weaknesses to this study which we just can't get around. So the comparator matched cohort have obviously had a COVID test. So there must have been some reason why they sought to have a COVID test. Either they were in contact with someone, they had a parent or a relative die, or they had the parent or relative ill and on ICU. And so they're not a true, they're not an absolutely pure control group in the sense that they've had some more exposure to COVID than people who've never had a test, but they're the best we can do for a comparator group. And finally, we're unable to incorporate a group of people who, as I say, who've never had a COVID test at all. So that's the weakness of the study, but I think that's a modest weakness. And I'm going to stop there, Okike. Thank you for giving me the time to talk to the 1,000 people online, and happy to take any questions during the panel.
Thank you. Thank you very much, Professor Sir Terence. It's been a pleasure listening to, obviously, what the future is in terms of long COVID. Now, this brings us to the end of all the planned talks, and I'm very pleased that all the speakers stuck to time, which gives us plenty of time to address some questions that have been highlighted by delegates. Before I go into those questions, just whilst all the speakers are getting ready, I would like to maybe pay tribute and thanks to all the people who have helped in organizing today, from the past coordinator of the BPSU to the staff in the BPSU office, and all the people on the technical bit of today, and the speakers who are doing this in their own time as well. We've got plenty of questions that should keep us going for the next hour. No, I'm only joking, for the next 25 minutes. So if I may start with you, Professor Knight, do we know why there's a difference in the management of COVID-19 in pregnant women?
So sadly, I have the responsibility for investigating all maternal deaths from any cause throughout the UK. And sadly, it's a pattern we see across many causes of death in pregnancy. There is a very, very risk averse and, dare I say it, lack of knowledge around what treatment can be used in pregnancy. And there tends to be, I'm hesitant to say this to an audience of paediatricians, but more concern over the pregnancy than over the woman. So although there is very clear guidance from jointly from the RCOG, RCPCH and RCM, it's clear that people don't necessarily know about that, and the default is to not treat as opposed to treat and or find the person who knows. So it is the reason that I put that in the corner of my slide, that little scales thinking about risks and balances, and we need to change the conversation from thinking about the risks of treatment to actually the benefits of treatment, and making sure that we're doing both sides of that weighing up.
Just a follow-up on that, someone asked, do you think it's people thinking about the impact of steroid, for example, on the fetus, that would have stopped people from treating?
So it may well be, because we know that there are concerns about dexamethasone for 10 days, but that's why the guidance is specific that for pregnant women you should use hydrocortisone or prednisolone. So I don't think there's an excuse for not treating women with steroids.
If I may move to I want to get round, I'll probably come back to you again so that I can get through to all the speakers and answer the questions that come through. So there was a question about the nosocomial transmission. So the question was around, do we know whether this was, do you know the unit firstly, then was it before the wide use of masks around units and PPE? What, do you have any comments on that?
We are looking into this. It's difficult because, of course, I'm sure everybody remembers back to the to the period where the data comes from, which was at the beginning of the first peak in the UK, and guidance around PPE use on neonatal units was a rapidly changing field. So different policies and different approaches were changing in an almost kind of week by week basis. So it's really hard to draw that out. We are looking and trying to understand some of the infection control practices, and in particular how looking after babies born to mums with SARS-CoV-2 has impacted on the delivery of neonatal services. I think that's another area of indirect effect. But it's been impossible to tease out the impact of different policies, and especially as there were only 8 babies. So, you know, the numbers are small, although the fact that it's about 10% of all of the cases is obviously quite worrying.
Thank you. If I may go to you, Professor Ladhani, we didn't have time for questions early on, but there's a lot of interest. Do you know if there's, you talked about other coronaviruses and SARS-CoV-2. Is there any evidence that children who have been infected with other coronaviruses also have protection against COVID-19?
So that's a really interesting question. I don't think we've come to the bottom of it. There are people trying to do that type of study. So what we found is that if you have COVID, well, if children have COVID, they develop very strong immune responses that also protect against other beta coronaviruses, which are similar to SARS-CoV-2. What we haven't shown is the other way around. What was very interesting is that quite a few children who had no antibodies to SARS-CoV-2 had a cellular response to the virus. And there's only 2 possibilities. One is that they were exposed to the virus, they didn't develop antibodies, but they developed a cellular response. Or the other possibility was that this was cross-reactive to previous coronaviruses, but we haven't been able to see that. And if you look at other studies that have been done, the amount of other coronavirus antibodies in those who got COVID and didn't get COVID was almost the same, which would suggest that having antibodies against coronaviruses did not help protect against COVID. So the answer is out there, but right now I found no evidence that would support prior coronaviruses being protective against COVID, but that could change.
Okay, bringing us to change, do you think that have you learned anything that can tell us how and the role of children in herd immunity in all this pandemic?
Okike, that's a really, really good question, and I think people misunderstand what herd immunity means, and it's very important that this messaging is right. Herd immunity is not about the proportion of the population that is immune to the virus. Herd immunity refers to protecting those who are most at risk of transmitting, and by reducing transmission from the highest group, you protect everybody else. If you look at the pneumococcal vaccine program, for example, vaccinating children under 2 gives you herd immunity for the whole population, including all adults. You don't have to vaccinate 50 or 70% of the population. You just target the group that is most likely to spread the pneumococcal bacteria. For meningococcus, it's the same thing. If you vaccinate teenagers, you can get herd immunity, which will reduce cases in the other age groups because the teenagers stop spreading the meningococcal bacteria. For SARS-CoV-2, it is likely that the same principles are in play. And as far as we understand right now, the young adults are the highest risk, highest transmitters within the communities. And it's very possible that by vaccinating adults, especially young adults, we can interrupt transmission to everybody else in the community and protect the older adults even better, even though they're vaccinated, and even children. So you see that in Israel, for example, cases in under 16s have fallen very rapidly, even though they have opened up now and are not in lockdown. And the most likely reason for the drop in childhood cases is because they've vaccinated all the adults, and therefore the virus is not being passed on to the children.
Okay, thank you, Professor Ladhani. I know you've dragged us into the vaccination. So if you want to know more about vaccinating children and vaccination of COVID, join us on Thursday. I would probably just move on to Professor Terence, in the sense that you have a question here. would you consider inviting allied professionals in your Delphi panel? That's a question from one of the delegates. Professor Terence.
Absolutely, they will definitely be key. One of the key parts of a Delphi consensus process is that it is a consensus, so it needs all the key stakeholders, and it will definitely not be confined to doctors, or for that matter confined to paediatricians. It will draw from primary care and secondary care, and it will definitely draw allied health professionals, no question.
Okay, and then there's another question for you in terms of your case, your matched group. Someone's asked you, have you considered that some of the children in the matched group may have previously had asymptomatic COVID? We heard from Professor Ladhani how asymptomatic infection is not uncommon in children.
Sure, that's a possibility. So we do ask them about their previous symptoms, and we can track and link whether they've ever, so if they've had a negative test and become positive, we can analyze them differently. But there's no way of knowing. It's certainly a possibility that some of the COVID negative people will have had an asymptomatic COVID infection, never had a test. That's for sure, that's possible.
So, Okike, it's Shamez over here, and I think also it's very important that we get the messaging right, because are we really going to start suggesting that having asymptomatic infection will lead to long COVID symptoms or acute post-COVID symptoms? It's very important that we clarify what we are trying to identify. We did a very similar study in adults where we measured antibodies in adults, and asymptomatic adults with COVID were almost identical to the control group, and it was only the symptomatic adults with COVID who had symptoms that might be suggestive of long COVID. At this stage, I think it's a very dangerous path to go down to suggest that asymptomatic infections can lead to long COVID without more evidence.
Brilliant. Thanks for that clarification. Because I'm aware of the global audience listening to this, and we've been watching on the news about COVID in other parts of the world, including Brazil and India. I wanted to ask you, Dr. Oligbu, do you know of any recent report about increase in PIMS-TS in Brazil, and how could you explain that?
I've heard about the increase in PIMS-TS in Brazil. And coming down to the study we conducted here in UK, we observed that there is a typical trend that after the peak of the COVID cases in the general population, we now see the rise of PIMS-TS in children as well. And this tends to lag behind about 2 to 3 weeks for the PIMS-TS to come along after the COVID cases. And it's not surprising that in Brazil now that are having a large number of COVID cases in the population, that they will start seeing associated rise in their PIMS-TS cases as well. But having said that, the report that is coming down is about 2,000 cases of PIMS-TS. But if you look at the population of Brazil as a whole, this is still rare in terms of the number of positive COVID cases they are having. So compared to the PIMS-TS that has been reported. So PIMS-TS is associated, there's an association, a relationship to COVID-19 cases that has been established here.
Okay, thank you very much. Very quickly, can you tell us whether there's a reason for the differing rate of post-infectious inflammatory syndrome between adults and children? This could be between you and Shamez, Professor Ladhani, or Godwin.
I think if you look at the PIMS-TS in children, and we know that most of the cases that we saw here, the COVID sampling was negative, you know. So it just shows that while they are trying to mount the immunity against the virus, that is when the PIMS-TS started occurring. It just shows about immune dysregulation. But cases that were seen in adults, to my understanding, is usually due to the virus itself. You know, so it all depends on how the body, and as you know, the immunity in children and adults differs. And the way Dr. Chris Gale has said before, compared to neonate as well, our immunity differs. So adults, the way they mount immunity diseases differ slightly from the way children mount response to diseases as well. So that might show the differences in which they present with this hyperinflammatory syndrome. Shamez may want to put a word on that as well.
He's smiling. Yeah, go ahead.
Okay, no, it's a very, very good question, and it is clearly an age effect, and nobody would be surprised if adults also had PIMS-TS variants. But what we do know is they're not as common as children, and I think it comes down to understanding the Kawasaki syndrome as such. We know that is there are multiple different triggers to Kawasaki disease, and multiple viruses could potentially cause it. It's not just SARS-CoV. And typically what happens is in Kawasaki disease, it's among the younger children who are first exposed to these viruses. And as you get older, what happens is either you are exposed and you get Kawasaki disease, or you're exposed and you have a normal immune response and don't get Kawasaki disease. So as you get older, your risk of Kawasaki disease goes down. With SARS-CoV-2, the difference is that we've never had a virus like this. So all age groups got exposed to very high loads of the virus very, very quickly. So one of the things that you see is, for example, the age at PIMS-TS is much higher. It's closer to 10 years compared to Kawasaki, which is closer to 3 or 4 years. And that's because of the lack of exposure to the virus in the beginning. And what we will find is as this becomes predominant, as the virus spreads through the pandemic and people are exposed to the virus or are vaccinated, SARS-CoV will just become another trigger of Kawasaki disease, and we should be seeing them at a much younger age. It's just an exposure effect. That's why we're seeing it in the older children and in the young adults. Once the population is either exposed to the virus or the vaccine, it will then become a childhood disease, just like Kawasaki disease.
Thank you. I have plenty of more questions, but we are kind of going extra time, and I'm quite happy to just ask a few more. But in general, this is question to Professor Terence Stephenson, but maybe others may touch on it. This is from someone in Save the Children. So what are the key challenges for ensuring meaningful participation of children in scientific research?
Well, that's quite a broad question that doesn't just apply to long COVID, but under great length, proper informed consent. So how have we done that? Well, for people aged 16 to 18, they are able to consent in their own capacity. Under 16, we have a consent form completed by their parent or carer, and then an assent form completed by the young person. Of course, with online research, you cannot prove that the person filling that in is necessarily there. So we've gone to as many lengths as we can. It's non-invasive research. We have in place mechanisms to mitigate risk and harm. We give people advice on where they can seek help, and we make really clear that we are not there to treat. We cannot help young people who have symptoms. And I think, and finally, we adhere to the idea that you can't, a long time ago we learned you can't do research on adults. If you want to find out about disease in children and young people, you have to do research on children and young people. And I think there's a lot of evidence that they are as willing to participate and as philanthropic in that sense as adults. But it's a big question and a very, very valid one. Oh, and I should have said, we offer two other things to assist. One is we've got the question, information we send out, postal, can be translated into the 7 commonest languages other than English in use in England. We also have the option of a paper questionnaire. We also can get everything translated, and we have the option of a person who speaks their first language assisting them, leading them through completing the questionnaire. So those are all other measures to help young people feel comfortable with this. Thanks, Okike.
There's also some a question that really relates to, I know your study is going to take some time, maybe your Shamez can answer this, that services need an answer now. Have they given you a timeline in terms of your results is going to come in time, but what will services be doing in addressing this long COVID in the meantime?
Okay, so we're in close collaboration with NHS England, who are setting up services for long COVID. I think the initial idea there may be around a dozen hubs across England in big centres, then offering advice to others. Clearly, we will share with them our data as soon as possible to help them design their services. And recruitment is going well, and we would be reasonably optimistic that we would have some data on symptoms 3 months post-COVID by perhaps something like June, as early as June, which is sooner than we perhaps anticipated, but recruitment's going well. So hopefully that will help inform NHS England in setting up services. The other very good news, which I think again reflects the collaborative enterprise of the last year during COVID, is that the clinicians setting up those long COVID services for children and young people want to use exactly the same questionnaire as we have developed with ISARIC for use in this research. And so collecting the same data as we're collecting is really helpful, because they'll have a population of young people, presumably at the more severe end of the spectrum, people who have justified referral. They're going to use that as a justification for referral from primary care to secondary care. They're going to use it for clinical decision making, and we'll then be able to compare their data with the data that we generate from our randomly generated COVID positive and COVID negative young people. And I think that's again a very big step forward.
Brilliant. Thank you. And last one for, yes?
There is just one more important point that I wanted to point it out. And it's that, you know, these services should not only be focusing on post-COVID syndromes where we think children have been affected by the disease itself. I think what's important is the pandemic has taken a toll on the rest of the population. The lockdown has had major effects, especially in teenagers. And what is really important is to provide a service to support all the children, irrespective of whether it was due to COVID or not due to COVID. So I think the messaging has to be right in that when we try to provide service through NHS, for example, that this service is not for those who have COVID, it's for those who have been affected by the pandemic, which may be due to COVID or may simply be due to lockdown. And if they have symptoms and they are worried, then they need support. And it's really important that that messaging is correct.
I would love to go on and on, but I think we have to come to maybe a point where I need to thank all the speakers. If you would join me in clapping for them wherever you are, whichever part of the world you're in. And also thank yourselves for joining in and making this event a success. Like I said earlier, this event has been recorded and will be posted online through the BPSU site in the Royal College of Pediatrics and Child Health. But this is not the end. On the second day, which is the 29th of April at 6 o'clock, we will come back again to address the other impacts of COVID in children. And we've got studies and speakers lined up for you again, particularly all your questions about immunization, other viruses, and COVID in educational settings. Those will be addressed next Thursday. So again, thanking all the organizers from the BPSU, the Royal College and Public Health England, and all the speakers and everyone who's contributed to this production. I want to say thank you to everyone